cell phones.
Okay, we're live. We'll do it.
Thumbs up when you're ready, sir.
Ready to go?
1 minute.
Okay, the live stream is going and it had not actually started. So
All cameras live, all mics
Yep.
live. All right,
So we're ready to start?
we're ready to start.
All right, I think we have all of our technology lined up. I'd like to call the meeting to order and announce that all requirements of the Open Meeting Act have been met. I'd like to remind everyone that even though this is a virtual meeting, we will observe the rules and decorum of a regular in-person meeting. I'd also like to welcome everyone joining by Zoom or on YouTube live stream. Finally, I'd like to announce that if the meeting is disconnected, the meeting will recess, reconnect, and reconvene. If connection cannot be restored after 1 hour, this regular meeting will be reconvened on Friday, May 22nd at 2:30 p.m. at the Edmond Conference Center.
That will be,
That's the wrong date.
yeah, August 28th.
August 28th at 2:30.
Thank you.
I'd like to state that there will be a period for public comment near the end of the meeting. If you're joining through your computer or Zoom, you can raise your virtual hand or state your request in the chat feature. If you're joining by phone and would like to participate in the public comment, text your name and phone number to 405-642-6860. Again, that public comment period will take place near the end of the meeting. I will recognize you when it's your turn to speak, and you will be unmuted. Comments will be limited to 2 minutes and must pertain to items listed on the agenda. Obscene or offensive disruptions or comments in the chat will get the offender removed from the Zoom meeting. Now for the next order of business, approval of the minutes of the May 19, 2020 regular board meeting. Is there a motion?
Yes.
Second.
It's been moved and seconded. Roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblain,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
and Marshall Snipes.
Yes.
All right. For the chair's report, I would like to introduce a new member of the TSET Board of Directors. I'd like to introduce Susanna Gattoni. Susanna was appointed to the TSET Board of Directors by the State Auditor and Inspector, Cindy Bird. She represents Congressional District 5. Gattoni is the Associate General Counsel of the University of Oklahoma. Welcome, Susanna.
Thank you very much. It's an honor to join this board.
All right, thank you. I'd like to now move on to the Executive Director's report. Julie?
Great, thank you. Well, since the last time that we met, the language for State Question 814 has been finalized. The election for State Question 814 will be in November. And as you may recall, the state question is a result of Senate Joint Resolution 45 that seeks to reduce the annual allocation to the TSET endowment from 75% of the annual payment from big tobacco to 25%. The state question language says that the money would go to the legislature to fund Medicaid. Also, since the last time we got together, the Legislative Office of Fiscal Transparency has met, and the legislative committee that oversees the new agency approved the group's work plan. An evaluation of TSET's tobacco cessation expenditures, programs, and program outcomes is among the top priority for this new office to evaluate. We anticipate working with this group this fall, and the timeline for a report to be released to the public is roughly 6 to 8 months from when the evaluation begins. Major agency work continues. We have successfully closed out our fiscal year. We still have some remaining invoices coming in, but we've also wound down our first wave of the Healthy Living Program. That ended June 30th and started up a new wave of the Healthy Living Program, a 5-year program. A new cohort of grantees are being onboarded, and our program staff and partners and technical assistance providers have made quick work of moving in-person trainings to online training. And as many of you know, that's no small feat. Also, our community grants continue to be impacted by COVID-19, especially our county health departments. Some of those staff are assisting with the local response in their community, and our program staff continue to work with those entities to be flexible, but also keep program training milestones and deliverables in mind. As for outreach, the outreach staff and myself, we have continued to virtually attend conferences and present. I've attended Governor Stitt's Leadership Summit with other state agency leaders, as well as the Center for Disease Control and Prevention training for new tobacco cessation grants. Oklahoma was recently awarded one of those, the State Department of Health, and we will work closely with them. And also this next quarter, the executive team will be preparing the agency budget request. It's important to note that TSET does not request money from the legislature, but we do provide information every year that goes into the state system and is available for their viewing. Office staffing, our office continues to have staff daily. We are adhering to social distance recommendations. We have staggered staff, and our employees have been successful in working remotely, as we have been a paperless office for more than a year. And very proud to report that our team continues to meet deadlines, milestones, and exceed expectations in this pandemic environment.
All right, thank you, Julie. We'd now like to move on to the Programs Committee report, which I will report on. The first item from the Programs Committee is a discussion and possible action on funding TSET food system impact grants. On June 29, TSET issued a request for proposals for a new funding opportunity, the TSET food system impact grants. The purpose of the request for proposals was to identify immediate needs for funding support for the state's food systems in an effort to increase access to healthy, nutritious foods for Oklahomans. TSET received 20 proposals. The proposals were vetted by a panel of 16 external reviewers from around the country. At the conclusion of the reviewers' discussions, the Programs Committee reviewed all scores and project summaries, and giving preference to proposals that most clearly aligned with the strategic goals of the board and the agency's strategic plan and goals to reach priority populations. The Programs Committee recommended 7 proposals for funding for a total of $1 million. Each award, if approved by the board, will result in a 12-month agreement between TSET and the applicant organizations. The Program Committee recommends the following projects for funding. Boys and Girls Club of Ottawa County, $36,072. Gateway to Prevention and Recovery, Food System Impact in Potawatomi, Seminole, and Hughes counties, $250,000. Hartford County Development Authority, That's the Laverne Food Security Cooperative, $40,395. Hunger Free Oklahoma, Double Up Oklahoma Grocery Store Expansion, $408,505. Regional Food Bank of Oklahoma, serving senior citizens program, Northeast Oklahoma City, Yukon, Frederick, and more, $96,544. RSVP Enid. The project title was Enid Mobile Meals and Food Distribution Systems serving Woodward, Major, Alfalfa, Grant, Kay, Noble, Garfield, and Kingfisher counties. $117,634. And then the last one's Urban Strategies. Project title, River West Healthy and Sustainable Food System Project Tulsa, $50,850. This came up from the Programs Committee. It does not require a second. Is there any further discussion? In the
Can I ask,
Yes.
Bruce, this is Marshall. Let me just ask one question. Where in our budget does this appear?
Marshall, this, if you remember, we had grants last fiscal year that were lapsing funds, and we recovered that lapse and are using those funds from last year that would have been carryover to fund this. And if this is approved, it will be part of the program budget.
For FY20?
Correct.
Yes, okay. Thank you.
Julie, this is Ken. What kind of geographic coverage does this get us in the state?
Yeah, great question. So one of the things that the program committee also looked at in evaluating the proposals were communities that were not necessarily served by some of our other grants. So this will expand our footprint in western and rural Oklahoma, as well as picking up on some high priority counties in central Oklahoma.
Any further discussion or questions? Roll call.
Jack needs to turn on his video to vote.
For some reason, it's not turning on. I don't know why. I've done 500 Zooms, and this is the first time it didn't turn on. I guess, I actually look pretty good today, too. I don't understand. It makes no sense.
We're going to check on our end. If you could hold for a sec, because that is a requirement for voting.
Let's see if that works. Guess what? It worked. You guys see me? I see myself.
Yes, we can see you now, Jack.
Perfect.
Okay.
Okay, so you guys were blocking me.
Yeah, sorry about that. We're also secure. Board Secretary, call the roll.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblane,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
and Marshall Snipes.
Yes.
All right, thank you. Next item, discussion and possible action on FY21 incentive grant criteria. Both the schools and community incentive grant programs have been redesigned to support stronger policies and practices in schools and communities, as well closely aligned with HLP activities. Jonas will briefly review the major changes.
Hello, everyone. Yes, our incentive grant programs have been revised to strengthen the policies that local communities and schools adopt, as well as the impact that those policies have when they're implemented. So I'm going to go through just a couple of items to note the changes that have occurred. If you've got your packet, it's on page 13, I believe. And so across both programs, obviously the amount of funding available has changed. It's 950,000 and it's evenly divided. There are 2 application periods rather than 3. We'll have a third one if funding is available. Policies are much more closely aligned to the Healthy Living Program policies. They're stronger policies. Both programs carry an evaluation component regarding the impact to the communities and schools. With regard to districts and schools, they're open to all districts and schools. Individual schools can apply once their district is funded. This year, we've added a crisis management component for not only COVID-19 related emergencies, but also other kinds of emergencies. And then the other fundable projects remain basically the same, and those are on page 14 in your packet. With regard to the districts can apply for the next level of funding if they've met the prior level criteria, as long as they're not at the gold level and have implemented their policies. So our staff check to make sure that policies are being implemented at the school level and the district level. With individual schools, nearly all the wellness policy elements, which means tobacco control, physical activity, and nutrition, are required at the 1-star level. We also have made sure that schools are receiving credit for their, if they're involved in the Program of Excellence for Safe and Healthy Schools, which is a program of the State Department of Education. The policies are in your packet. I'm not going to go through each of them, but they're on pages 17 and 25. They include comprehensive 24/7 tobacco-free policy, including vaping, having a wellness committee, incorporating best practices from the CDC, that's the Center for Disease Control and Prevention, emergency operation plans, and then school nutrition policies that must meet the USDA requirements. On the community side, our grants are open to all cities and municipalities that have not previously achieved the gold level, which is the top level. Funding is based on the community size, and you'll find that on page 15 of your packet. With regard to the policies, they must have tobacco-free and vape-free ordinances and have a wellness committee, a workplace wellness committee. The worksite wellness policies adopted must have, again, tobacco, physical activity, and nutrition. And there are different levels of policy based on the number of employees, because obviously some cities and municipalities are smaller than others. They need to promote Shape Your Future in the community. They should have shared use agreements for public access to facilities. Also have a requirement that they have healthy events as a city at the gold level. And then the projects there are essentially the same as previously. The details for this program are provided on pages 26 through 29. Just some ideas about the ordinances and policies. City can adopt an ordinance that prohibits smoking and use of tobacco products, including e-cigarettes and vaping in all indoor and outdoor city-owned properties. All primary, secondary, and higher education institutions in the community need to be tobacco-free. Zoning or land use policies need to be supportive of community gardens and farmers markets. These community grants also need to have sort of local action by various bodies. So for example, cities need to show that they've implemented healthy food improvements by establishing community gardens and farmers markets, or that they've made physical activity improvements by providing additional equipment and splash pads, etc. Are there any questions?
All right. Thank you, Hanas. This came up for the Programs Committee. It's a recommendation. It does not require a second. Any further discussion or questions from the board?
I've got one. So in looking at these, especially community, are we thinking this is making it more difficult for them to get there? Are we upping the level of requirement for the incentive grants with the new criteria? Or expanding it in ways? I mean, how much more?
We're we're actually strengthening the policies. So for example, with schools, we're making sure that districts provide or allow at least 10 minutes to the students to eat breakfast and 20 minutes to eat lunch. Making sure that food and beverages provided on campus meet the USDA SMART requirements. So they're a little higher level. And we have found, I think, as you know, that in the past, like last year, we essentially ran out of money early in the year. So that's spurred us to think, maybe we need to strengthen policies as well as the local activities that they should have in place. And so that's what this is going to. I don't think it's going to exclude anyone when it comes to certain policy elements. They can incrementally strengthen their policy. They don't have to meet the gold standard. And so we watch for that.
I guess that was my question. I know we were strengthening because, we had so many that were meeting it. And I just don't want us to get to the point where now we're actually not getting the money allocated and getting it out there.
I think we'll be able to get it out. And so we're looking forward to, funding communities and schools. Yeah.
Great. Okay.
Thank you, Casey. Any other questions from the board? If not, roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblane,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
and Marshall Snipes.
Yes.
All right, thank you. The next item on the agenda is discussion and possible action on Free the Night. Free the Night is a statewide campaign that encourages bars and clubs to voluntarily adapt smoke-free policies. With the bar and club closures in Oklahoma due to the COVID pandemic, the Free the Night campaign revamped their FY20 fourth quarter strategies, that's May, June, and July, to focus on providing information to bar and club owners about financial support, resources, and social distance measures in the event of reopening. If the COVID climate remains as it currently exists, it may be difficult for Free the Night to have strong and vigorous outcomes due to the environmental limitations. Discussion on whether to continue the program is at issue. The contract can be terminated with 30 days notice by either party. It is recommended that the board consider the termination of the Free the Night program given the current climate. It is further recommended that if the board chooses to terminate the Free the Night program, that a 90-day termination date following board action be considered in order to allow an appropriate shutdown with the program. This is a recommendation from the program committee. Second is not required. Discussion by the board.
Well, if it's not working, why keep funding it?
I think that it's important to note, and you'll see that in your packet, that in a previous environment, they were successful in outreach and providing technical assistance for voluntary policy, but that environment has changed. And this is about 0.5% of our overall program budget. And so we bring this recommendation to the board.
Yeah, I just want to go on record. It's always been my favorite. I'm sad to see that it needs to close for right now.
Yeah, I mean, the concept is great, but like I say,
They can't function, right? And they're okay, Julie, when you all, what we still get our proprietary information and the stuff that they've created.
Yes, so that 90-day shutdown will allow us to transfer those assets. The bar finder will likely migrate and be part of Tobacco Stops with Me, as we know patrons, if and when a different environment opens up, that smoke-free is important to consumers. And so we anticipate a seamless transfer of assets from this program.
So we do get to keep that, the key in to find a smokeless bar.
Yes.
Okay.
All right. In the absence of further questions, roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblain,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
Marshall Snipes.
Yes.
All right, thank you. Next item on the agenda is overview of new TSET Healthy Living Program service area and activities. Jessica Davis, our Senior Program Officer, will provide a presentation on the enhancements made to our approach to community-based programs, specifically the change in the number of and types of grantees, our emphasis of working in counties having the lowest health rankings, using data to pinpoint hotspots for HLP work, and connecting local needs to corresponding best practice strategies. The chair recognizes Jessica for a 10-minute presentation. We'll allow time at the end for board questions. Jessica.
Hi, everyone. My name is Jessica Davis, and I'm a Senior Program Officer at TSET. And I would like to thank the board for allowing me the opportunity to speak with you today to provide an overview of our TSET Healthy Living program. Next slide, please. Before I dive into the details of the new TSET Healthy Living Program grant, I want to discuss some of the primary differences between the original TSET Healthy Living Program grant and the one that we just launched in July. The original HLP grant was comprised of a sector-based approach that focused on work with the largest organizations within the grantee's service area. For the new initiative, greater access to county-specific data has allowed us to identify at-risk or priority communities prior to the release of the Healthy Living Program RFP. The mindset is if funded community grantees focus on areas within the state that have the poorest health outcomes, there's a greater chance of impacting behaviors that drive poor health outcomes related to obesity and tobacco use. This will be accomplished through data-driven decision-making and selecting strategies that will address the barriers that exist within a hotspot region. Another key difference between the two initiatives is around strategy selection. For the previous grant, TSET assigned 12 required strategies or outcomes that each grant had to work on throughout the initiative. They also had an option to pick up additional strategies according to the issues that they were seeing in the community. For our new grant, strategy selection is based on the priorities that are identified through our comprehensive community needs assessment. Grantees will select between 9 to 12 strategies related to physical activity, nutrition, and tobacco control. The selected strategies must be data-driven and align with the local needs assessment results. Additionally, in the new initiative, we have a few environmental strategies that are not related to policy passage. Some of these include strategies to address youth access to tobacco, which includes merchant education, as well as working with law enforcement to enforce the laws, and healthy food options within local restaurants. However, we acknowledge that policy work remains a critical component of the grant, but we also know changes in the environment are also critical in making an impact on health outcomes. Lastly, the biggest difference that you'll notice is the number of grantees that we have. For the original initiative, we had 50 grantees, which covered 63 counties across Oklahoma. We ended the initiative with 47 grantees covering 62 counties. 2 of these originally funded grantees ended up giving up their grant, while 1 grantee combined with another TSET HLP grant to form a consortium comprised of 2 counties. Our new initiative has 35 grantees covering 37 counties across Oklahoma. 21 of the 37 counties that are funded are considered priority counties, which means they have some of the poorest health outcomes in our state. Next slide, please. This slide shows the county coverage for the original Healthy Living Program and our new Healthy Living Program grant. For the original HLP grant, we funded all of the colored counties that you see on the map, the green counties along with the blue counties. The counties that are in green are no longer hold the TSET HLP grant, either because they didn't apply for the grant or because their proposal did not meet our funding thresholds. The counties that you see in blue represent the new grantees for the Healthy Living Program Initiative. Next slide, please. This slide lists only the counties that have been funded under the new initiative, along with the population estimates for each county. The purple counties on the map are considered priority counties. In order to determine priority counties, average scores for three categories were taken in regards to morbidity and mortality factors, social and economic factors, and clinical care factors. And they were ranked between 1 to 77, with 77 being the worst. The process that we used is very similar to the process used by Robert Wood Johnson Foundation to determine county health rankings that they release annually. However, the key difference between our process is that we used more current behavioral risk factor surveillance system data with our rankings. The counties in green are considered non-priority counties. However, it's really important to note that Oklahoma consistently ranks at the bottom as far as poor health goes. So therefore, every county in Oklahoma could benefit from the work of the TSET Healthy Living Program. Next slide, please. In order to better understand what Healthy Living Program grantees will be doing over this next year, I'd like to walk you through some of the data that they will use to analyze hotspot areas within their service region. And this is going to be the first milestone of the Healthy Living Program grant. This data will also be used by grantees to determine which strategies will be the best fit to address the factors that are driving those poor health outcomes within their service area. Since 2017, Healthy Living Program grantees have had access to what we call Wellness County Profiles, which consists of Oklahoma maps and county dashboards and houses a wealth of data related to tobacco control and obesity. These profiles were included in the Healthy Living Program 2.0 RFP, and they were updated again in July of 2020. At the beginning of each profile, you'll find state maps that enable counties to see where they stand in comparison of their neighboring counties around risk factors such as smoking, obesity, cardiovascular disease, cancer, food deserts, and there's additional factors that we consider. With our recent update, we included 5 new maps, which includes aerobic physical activity, area deprivation index, which is looking at social determinants of health, tobacco retailer density, child opportunity index, and life expectancy numbers. TSET grantees commonly use these maps to visually show stakeholders how their county stands compared to other counties. And sometimes it results in a little bit of friendly competition on their end. Next slide, please. And so this slide shows the health outcomes dashboard that's within the county profiles. These profiles display trends for risk factors or health outcomes related to tobacco and obesity. These align with the Oklahoma maps mentioned on the previous slides. These factors are separated, you'll see those green arrows, by tobacco, obesity, and mortality. You can find the county's data trends from 2013 to 2018 for each indicator with a corresponding 6-year trend line. And the status column, which again compares to the 2018 county data to the state and gives an icon described in the legend below. You'll see the thumbs down means that the county information, the county is worse than the state outcome, while the kind of the yellow thumb is within 0.5% of the state outcome. Next slide, please. For the new TSET Healthy Living Program Initiative, we have upped our game and now have access to census tract and block group data. This data is packaged into profiles for each TSET HLP county. With the picture on your screen, you'll see a hierarchy of census tracts. Within Oklahoma, we have 77 counties. Each county is made up of census tracts, and there are 1,046 census tracts in our state. Each census tract has a unique number and generally contain 1,200 to 8,000 people with an optimum population of 4,000. Nested in the census tracts are what we call block groups. There are 2,965 block groups in Oklahoma. A block group can contain between 600 and 3,000 people. Cities and boundaries are not contained within the census tracts, but they can overlay multiple census tracts. But census tracts do not cross into overlying counties. It's important to note that it's important to look at the data at the census tract and block group levels because oftentimes the underlying causes of poor health outcomes are due to circumstances outside of healthcare systems and are actually linked to the conditions in which people are born, grow, live, learn, play, work, and age. These social determinants of health can drive as much as 80% of the health outcomes. This essentially means that where we live affects our opportunity to be healthy. We also know that the county level data is not enough to capture health disparities and inequities that can exist between people living in the same areas. Now let's take a look at some of the data found within the census tract and block group profiles. Next slide, please. Okay, this slide's a little bit messed up, but I'll try to walk you through it. So here's an example of some of the information that grantees have access to within the census tract profile. And this is the information that grantees will primarily use to identify hotspots within their service area. Each table has a gray header that you kind of see at the top of the screen. And so on this slide right here, you'll notice that there are 3 census tracts. And these are the census tracts that are within McIntosh County. Each census tract shows on the second gray column, you'll see a population that's within the census tract. They also have what we call a Child Opportunity Index score, which can range from 1 to 100, 100 being the worst score, or 1 being the worst score and 100 being the best score. And so we have ranges of child opportunities being very, very low, low, moderate, high, or very high, as you can see from that legend on your screen. The Child Opportunity Index is a tool that describes and quantifies the neighborhood conditions that children experience today. You can also find at the far right of column my Zoom is disconnected. On the far right column, you can see the cities that are within the census tract.
You got a strong signal now. We hear you.
Okay, good deal. I'm just trying to find my place. And then
We're all trying to find our place. Don't worry.
We may have lost Jessica.
Yeah, she is.
Jessica, you're muted.
You're muted.
thank you guys. Appreciate your. Okay, so you'll notice on the rows that there are some different colors, oranges and greens and yellows that you'll see. So those colors represent what we call an area deprivation index value for each individual block group. The area deprivation index legend ranges from 1 being the least disadvantaged to 10 being the most disadvantaged. So these tables allow you to see a quick glance the most disadvantaged or socioeconomically deprived block groups and census tracts within a county. These also align with the maps that you'll see later in the index. In addition, there's block group level data around poverty, uninsured, unemployment, home ownership, high school graduates, age, and race and ethnicity. Next slide, please. So following the census tracts, each profile consists of census tract maps. The map on the left shows the census tract with the GIS view within the block groups numbered. So you'll see that there are the numbers that are circled 1 through 4, and you'll see on the right, you can see where there's 1 through 4. So those colors that are listed in the graph or the chart correspond with the numbers on the GIS map right there. So basically, the darker the red the number is, the more deprived that area is. And that would be an area that would be considered a hot spot within the block group that grantees would really want to focus their efforts on. Next slide, please. This diagram shows a thought process that grantees will go through when they are trying to plan their physical activity, nutrition, and tobacco control interventions after they have identified their hotspot region. First, grantees will look at health data, which can be found within the Wellness County profiles and census tract profiles I just gave you a glance at. As grantees are looking at the data, they will ask the question, why does our health data look this way? Why are our obesity rates so high? Why do so many people report poor health? And this will lead them to thoughts about health behaviors. They will then collect data to determine what types of health behaviors are driving the poor health outcomes. Some of the data may include information on how much fruits and vegetables people eat on a daily basis, or maybe how much exercise people get. And then they will ask again, why? Why don't people eat lots of fruits and vegetables? Or why don't people exercise much? In order to answer those questions, grantees will need to take a look at social and ecological factors like access to healthy food outlets, dangerous built environments, perhaps even difficulty using and discussing SNAP benefits. Finally, once grantees have explored all of the factors and collected data, they will be able to identify strategies related to policies, system changes, or environmental changes to address the identified issue within their hotspot region. So you can see that we're really taking a targeted approach and trying to tailor whatever strategies are selected according to the data that they're finding, making it a truly data-driven approach. This process will take place during the first year, the TSET Healthy Living Program grant, and will conclude early in FY22 at the latest. Next slide. Once the grantee completes the data collection and analysis process, the results will be used to inform the selection of policy, systems, and environmental and evidence-based implementation strategies that effectively address obesity and tobacco control in the geographical service area. The grantee may only select strategies that are listed within our TSET approved strategy menus, which are also included in the TSET HLP 2.0 RFP. All strategies are comprised of evidence-based and promising strategies. The strategies include information about the level of impact, which ranges from high, medium, and low. There are 33 strategies in total across all of the strategy menus. The strategies on this slide are not a comprehensive list. However, I just wanted to point out some of the new strategies that we have added to the list, along with the strategies that we would like to accelerate work in the future. Some of the nutrition strategy examples include expansion of healthy options within food banks and food pantries, recreational public interest menus, work within locally owned restaurants. Some of the physical activity strategies include work with local government to adopt policies and plan to increase safe and convenient opportunities for physical activity across local communities. This can be accomplished through policy work such as comprehensive plans, safe routes to school policies, master plans, etc. Lastly, tobacco strategies have been expanded to address youth access to tobacco, which supports and aligns with the Tobacco Stops with Me statewide policy goals. Grantees may also choose to work with businesses that are exempt from current clean indoor air law through the passage of smoke-free policies. After strategies are selected on a grantee's local needs assessment, they will be asked to complete a 2-year strategic plan. That is a high-level summary of the work ahead of our Healthy Living Program grantees during the first year of the grant. I want to thank you all for the opportunity to present this information to you today. Next slide. And does anyone have any questions for me?
Jessica, thank you for such a thorough report. It's now open for the board for questions.
So the first year of the grant is to do the assessment, the health data and all of that, and then they'll start actual, I mean, if they get through, is there a chance they'll get through all of the assessment and begin developing and implementing strategies within that first year?
We had a really robust assessment phase during the first year of the grant. It is likely that could potentially happen. I'm not sure. I think our process is very overwhelming for people because many people have never done a comprehensive community needs assessment. And the way that we put it together, we're really trying to set it up in a way where we're getting a true baseline for what's going on within the community, and we're taking a really targeted approach. Also, we are building in strategies or assessment data collection efforts to include community feedback through virtual world cafes and things like that. And these things just take time. We're also trying to navigate how to conduct needs assessments in a virtual environment, since many people have to abide by their agency policies where they can't go out and meet face to face. So I say all that to say, it could happen, but I don't think it would be likely that many people will begin implementing during the first year. But if they can, we will definitely support them.
And how many of these, remind me, actually were previous HLP grantees? What's the number? I mean, out of the 35 grantees, how many are old timers with us?
I believe that number is 33.
So there's 33 that had a previous HLP grant. So they should come up to speed a lot quicker.
Yeah.
Yeah, we have part of our needs assessment process, we are including some of the data that had previously been collected under our previous initiative. So they have access to all of that. A lot of them already have partners built and things like that. So there's a lot of assets and things that they already have in place. I think it's just building their capacity to our new process and gauging what baseline they have for the community, because some of we've never taken an approach where we have the data down to the block group level. So in some cases, some of their hotspot areas, they may have to build partners in those areas because they may have never focused on those areas before.
Okay.
So Jessica, on slide 40, which is the census tract and block group data, where does that information come from?
We are partners with the Center for Chronic Disease Prevention and Health Promotion, and they help us with surveillance. So they put these profiles together for us, and they grantees also have access to technical assistance from them. I've just had some grantees actually request some information on a county map with the social deprivation index, showing the pockets of the greatest need on a whole county map. So I'm not exactly sure where they obtain this data. I think it's Robert Wood Johnson. It's from a variety of different data sources, and they put together these profiles for us each year.
So I assume there are other agencies in state government, maybe this is a question for Julie, that also have access to the same information, or are we the only ones?
So if it's census data, then that's something that is available to anyone that requests it. Commerce does a good job of tracking that. I'm not sure of what other state agencies in the health cabinet do, but I'm sure that mental health probably does, as well as DHS. It's really about targeting resources to address inequities. And I think that that's key when we're talking about how do we move our entire population towards health? Obviously, you have to change the environment and get support among community leaders and stakeholders, but you also have to target resources to pockets that maybe are not keeping pace with other advancements.
Thank you.
Jessica, we clearly have some counties that have great need, but I'm not sure, I think did not apply. Do you have any idea for what the threshold is that is maybe keeping some groups from applying for support?
I'm not exactly sure. Sometimes it could be timing of the release of our request for proposal. Sometimes it could be the lack of knowledge of folks knowing about our grants and things like that. So I'm not sure what's inhibiting people from applying to begin with, but we are always really excited whenever we see new names. Whenever we're reviewing grants, we're always excited when we have new people that we've never funded before applying. I don't really have an answer for you. I'm sorry.
All right, thank you.
I think with this new approach too, in this first year, we are doing a lot of capacity building. Our veteran grantees, of course, are well-known and experts in their community, and we are adding a new skill to the toolkit. And so there's a very aggressive training schedule, and that is similar to grantee kickoff, but we are really drilling down on data to put resources where they are most needed.
Okay.
Well, and to kind of address the one question about the counties that, you know, I mean, you look there at Choctaw, surrounded by everybody. Our own county, Murray County and Johnston County, I mean, they're, and I'm not sure, I don't know why they don't apply, or to figure it out, but I'm wondering if there's a way to get them hopefully sucked into the other counties around them.
And, we can speak to what we have with other community-based programs that we've had over the years, 5-year programs. We know that there's a benefit to surrounding counties when an HLP, or if we go back to communities of excellence, we know that there's a regional benefit when those programs are in place. And some of it is, this was a high bar for applicants, this RFP, and they needed to demonstrate an understanding of data and how to use it. So we may be, with some of the food grants that you just awarded, you're hitting some of the other counties in a different sort of partnership.
Any other questions for Jessica? All right, thank you, Jessica. The next item on the agenda is a report on Health Systems Impact Grant Program Summary. Heather Ross, Senior Evaluation Coordinator, Hudson College of Public Health, will present on the accomplishments of the 3 agencies funded through the Health Systems Initiative. Those agencies are the Oklahoma Department of Mental Health and Substance Abuse Services, the Oklahoma Hospital Association, and the Oklahoma Healthcare Authority. Heather, I'd like to hear your report.
Good morning. I'm really pleased to be here with you today. My name is Heather Ross, and I've been the primary evaluator working with the Health Systems Initiative, or HSI, grantees for the past 6 years. And today I've been asked to provide you with a brief high-level summary of the HSI grant programs, their major accomplishments, and some estimates around the impact that these programs are having. Next slide. So we'll start with the Oklahoma Department of Mental Health and Substance Abuse Services program. I'll call it the ODMH program. It works to implement systems-based interventions that address tobacco cessation, nutrition, and physical activity for consumers and staff across their entire network of state-operated, contracted, and certified providers. ODMH uses strategies that include training, workforce development, contracting, assessments, and feedback reports to support the implementation of wellness policies, practices, and environmental changes. Next slide. So one area of grant focus has been policy change, and this slide highlights some of the grantees' achievements over the past few years. These achievements are also included on the one-pagers that you received in your packets. But as a quick summary, you can see that all contracted and certified providers are required to pass and implement tobacco-free campus policies. In addition, contracted providers are required to develop an enforcement plan for their policy, and they also have a requirement to refer at least 20% of their consumers that use tobacco to the helpline. Additionally, 30 organizations have voluntarily adopted comprehensive wellness policies, and these policies combined reach nearly 100,000 staff and consumers annually. Next slide. In terms of practice changes, referrals to the helpline have been a primary focus of this grant, and this has been the case since ODMH was initially funded under the Cessation Systems Initiative program. And as a result of this focus, in FY20, ODMH partner organizations averaged nearly 850 referrals per month. 97% of these referrals were made electronically, and that's really important because it ensures sustainability of the practice. Further, since FY16, the program has generated over 47,500 referrals. Another important change implemented by the program has been in the area of workforce development. As a result of grantee efforts, Wellness Coach has become an official agency certification. In order to be certified, wellness coaches must attend training, pass a certification test, and complete continuing education requirements annually. Once these requirements are met, wellness coaches are then eligible to bill for wellness services. And ODMH has gone the kind of extra mile here, and they now require that all of their health homes include a certified wellness coach on all consumer treatment teams. Currently, there are nearly 1,500 active wellness coaches, and since FY17, they've billed for nearly 1.7 million units of wellness services. Another strength of this program has been innovation. In FY17, they proposed a pilot program that would provide enough NRT to a consumer at discharge from a residential treatment facility to last until a supply from the helpline could be delivered. And during the first 3 years of that project, over 4,400 consumers have received the nicotine replacement therapy they need to support their quit attempts. Next slide. One new component of the HSI evaluation in FY20 was using the Prevention Impact Simulation Model, or PRISM, to estimate the future impact of these programs. So I'd like to provide a brief overview of what PRISM is and how it works. PRISM is a tool that helps users make informed decisions by modeling potential impacts of an intervention on a population's health. The model is built to understand and project cardiovascular and other chronic disease-related mortality and costs, and it can be used to estimate how systems and environmental improvements made now will affect these conditions and costs in the future. PRISM works by building on the public health dose literature, which at its most basic level says that the impact of an intervention is determined by the intervention's strength and the number of people the intervention reaches. In other words, a strong intervention that reaches a lot of people is going to have a bigger impact than a weak intervention that reaches fewer people. So for PRISM specifically, impact is measured by multiplying the intervention's strength by the percent of the population reached. So this might have you asking how the strength of an intervention is determined. And the simplest answer to that is through a literature review. So the developers of the model conducted a literature review to generate a list of evidence-based interventions. Then each intervention's strength was coded based on the published effect size of that intervention and the quality and quantity of the studies included in the review. Another important thing to know about how the PRISM approach works is that it uses an intention to treat model. And this means that the percent of the population reached represents the percent of people with access to an intervention, not just those who take part. For example, the population reached by a smoking cessation program offered at an ODMH site is not limited to the number of attendees. It includes all smokers who receive services at that site and therefore have the opportunity to participate in the group. So why do we use PRISM? HSI grantees report changes to policy, practice, and environment as part of their progress reporting. These measures are used to demonstrate the short-term impact of the program and what it's doing to create environments that support wellness. However, these policy and practice changes take time to impact population health. In fact, the changes to population health aren't likely to be measurable during the evaluation period. So that's why we use PRISM to project the potential long-term impact that the grantees programs are having on population health. Next slide, please. So on the next slide, I'm going to show you the results of the ODMH PRISM model. But before we review those, I want you to be aware of the following limitations of the data. So the first is that the model doesn't take into account everything that the grantee is doing or every strategy that they're implementing. Only programming that aligns with the predefined interventions included in the PRISM model are included in the analysis. So the table on this slide outlines the model levers or intervention areas that are included in the ODMH model. So in the area of nutrition, that's fruit and vegetable access and promotion. In physical activity, it's also access and promotion. For tobacco, the grantee's work touches on smoking quit services, marketing restrictions, and smoke-free multi-unit housing. And the clinical lever addressed is support services for people with psychological distress. The second limitation is that the results presented are really an estimate based on estimates. So there's a significant amount of variability around the true impact. This is why each projection that you'll see is going to include a point estimate and a 95% confidence interval. So while a point estimate is provided, it's really only an estimate, though the true impact is likely within the range of the confidence interval. Third, we ran the PRISM models for each HSI grantee independently from one another. So while the results do give you an idea of the program's impact, they can't be added together to estimate the total impact of the HSI initiative. And they really shouldn't be reviewed side by side to make comparisons between these programs. And that's because the programs and the populations they reach are really closely related. For example, an individual with Sooner Care might receive services from an ODMH site and an OHA site. So the same person can be touched by all three programs. And the models, how they stand now, that person would be counted as three different people. Finally, the model assumes sustainability, meaning the projections assume that the current interventions are going to continue with fidelity and with the same level of reach through the projection date. So if an intervention stopped tomorrow, the results of the model wouldn't be accurate. Next slide, please. So here are the results of the model. And again, just for a quick orientation to this slide, it shows the projected impact of the systems changes made since 2015 if sustained through 2025. And each projection includes a point estimate and below that a 95% confidence interval. So the results of the model show that the policy, practice, and environmental changes implemented by ODMH starting in 2015 are estimated to prevent 366 deaths and save over $33 million in medical costs if sustained through 2025. Likewise, it's estimated that if the programming is sustained through 2025, there will be approximately 7,800 fewer smokers in the state and 1,900 fewer obese adults. Next slide, please. So now we'll move on to the Oklahoma Hospital Association program. And the purpose of the OHA HSI program is to provide Oklahoma hospitals and their affiliated clinics with support to create sustainable systems change addressing clinical tobacco treatment and employee well-being. And this is accomplished through two separate programs within OHA's grant. The first is the Hospitals Helping Patients Quit program, and the second is called Work Healthy Hospitals. Next slide, please. So for a little bit of background, Oklahoma hospitals and outpatient clinics have an estimated 10.7 million patient visits per year. Unfortunately, the provision of evidence-based clinical tobacco treatment services in healthcare centers isn't currently a standard practice of care. However, evidence has shown that tobacco users who receive cessation services from their healthcare provider are significantly more likely to successfully quit compared to those who quit without clinical support. So in order to address this need, OHA developed the Hospitals Helping Patients Quit initiative, or HHPQ. And this initiative works with hospitals and their affiliated clinics to embed best practices in tobacco cessation into their clinical workflows. And what this really means is that they work with hospitals to improve their electronic medical records so that providers are prompted to deliver tobacco cessation counseling to patients that identify as tobacco users. Additionally, electronic referrals to the helpline are built into healthcare systems EMRs. So when you look at the program highlights here, you can see that 65 hospitals and over 340 clinics have implemented comprehensive tobacco cessation services. And since FY16, this has resulted in 32,000 referrals to the helpline. Additionally, 96 hospitals have adopted policies that regulate tobacco use on their property. Next slide, please. Hospitals are a large employer in Oklahoma. It's estimated they employ nearly 77,000 people in the state. So the Work Healthy program was designed to assist hospitals in creating an environment where employees can holistically thrive. So whereas the HHPQ program focuses on patient cessation, the Work Healthy program focuses on employee wellness. And to provide a little bit of context to the achievements of the program, I'll give you a quick breakdown of how Work Healthy works. So in order to participate, a hospital CEO signs a letter of commitment and the hospital pays for a license. Once payments received, the assessment, the Work Healthy assessment and the associated tools are unlocked. Hospitals take the assessment and receive a report outlining their results. And then based on their answers, hospitals receive a rating of bronze, silver, gold, or platinum for each of the 10 dimensions included in the assessment and listed on this slide. Using their results report, participating hospitals prioritize and implement changes in policy, practice, and environment to support employee health. This could be changes like adopting a tobacco-free campus policy, or including nutrition information on their cafeteria menu, or offering financial consultation to employees. Improvements can be made within any of those 10 dimensions of wellness. Hospitals are also encouraged to regularly reassess in order to track their improvement and to reprioritize their efforts. So it's really designed to be a continual cycle of improvement. There are currently 33 hospitals with active licenses. These hospitals employ nearly 27,000 people. And among active hospitals, 50% of the dimensions are currently classified as platinum, which is the highest level possible. Next slide, please. So we also ran a PRISM projection for the OHA program, and the model levers that could potentially be impacted through the work of this grantee are shown on this slide. The next slide is going to show the results of the model, and again, when reviewing the results, please recall the limitations that were outlined earlier. Next slide. Here again, the slide shows the projected impact of the systems changes made since 2015, if sustained through 2025. Each projection includes a point estimate and below that a 95% confidence interval. So the results of the model show that the work of the grantee since 2015 is estimated to prevent 1,378 deaths and save over $119 million in medical costs if sustained through 2025. Likewise, it's estimated that the programming, if sustained through 2025, will result in nearly 2,800 fewer smokers in the state and nearly 5,000 fewer obese adults. Next slide, please. The remaining HSI grantee is the Oklahoma Healthcare Authority. OHCA's HSI grant funds the Sooner Quit program. This program seeks to reduce the prevalence of tobacco use and obesity among adult Sooner Care members. OHCA uses strategies like billing changes, provider trainings, practice facilitation, and promotional media to remove barriers to tobacco cessation services, promote available tobacco cessation and nutrition counseling benefits, and also to increase the provision of tobacco cessation counseling by providers. Next slide. The most significant policy change implemented as a result of OHCA's HSI program were the changes made to the Sooner Care benefit for tobacco cessation services. And the goal of the benefit changes was to reduce barriers to using the tobacco cessation counseling and nicotine replacement therapy benefits that are provided through Sooner Care. So the changes made included the removal of co-pays and prior authorization for pharmacotherapy. Additionally, the list of provider types that can bill for tobacco cessation counseling was expanded. And this improved benefit is now available to over 86,000 adult tobacco users with Sooner Care coverage. Next slide. In addition to the benefit changes, the grantee has also implemented practice changes within OHCA and their partnering provider sites. So the program has engaged 50 healthcare sites in practice facilitation, and a pre-post measurement of practice facilitation sites shows that providers increased their tobacco cessation assessment score from 63% at baseline to 75% at follow-up on average. In addition, the work of the program staff has contributed to over 2,100 referrals to the helpline and over 35,000 claims per year related to tobacco cessation. Next slide. We also ran the PRISM projection for OHCA, and the OHCA program's primary focus has been tobacco cessation, and as a result, the only lever that their work aligned with in the PRISM model was smoking quit services. Next slide. Again, because OHCA's program doesn't touch upon physical activity or nutrition levers, their results don't include an estimate around the number of obese adults in the state. But that said, the work of the OHCA grant since 2015, if sustained through 2025, is estimated to prevent 316 premature deaths, reduce the number of smokers in the state by over 23,000, and result in over $37 million of medical costs saved. That's a pretty high-level look at these programs and their key achievements and an estimate of their projected impact. I'd like to thank you all for your time and attention, and please let us know if you have questions.
Thank you, Heather. Questions from the board?
Yes, I have one. In our budget for this year, we've got $1 million allocated to the incentive grants. And my question is, these results are fairly impressive. Are we fully funding these efforts? In other words, if we added more to the million, if we spent $2 million, would we get more bang for our buck? Because this return on investment here is pretty good. So I guess, are we fully funding, or if we funded more, would we get even better results?
I think that's a really good question. I mean, obviously, we're going to have a higher percentage of smokers within, our healthcare authority sooner care population. At the same time, I think it shows how all of these things work together, because people have to accept the benefit. So then that pulls in, what's happening at the local level, pulls in our public education campaign. We have not cut these programs. Now, if they were unable to spend their money last fiscal year because COVID did disrupt some timelines, we've used that for other things. But, I think that we're always looking for ways to improve and to add on, and it takes two to do these kind of things. So the partner has to be open to doing the additional work as well. I don't know if Jonas or Heather, if you want to add to that.
Well, a question on that. State again what our budgeted amount is. I thought health system initiatives were more than $1 million.
So let me look. Our total budget for the health systems initiative is $1.8 million, which is about 4% of our total program budget.
Okay, not the incentive grants.
I think Marcia was just referring to the incentive grants because of the $1 million there. I would say that with OHA, certainly they've touched quite a few hospitals, but there are many more that they could touch with both their programs. DMH has done primarily tobacco work. They could certainly expand into wellness in terms of physical activity and nutrition for their employees and clients. The Oklahoma Healthcare Authority could certainly have a greater reach around the sooner care population. I think they're trying to do that with having contractual requirements with Medicaid providers that are going to be required to adopt and implement tobacco-free campuses.
Yeah, the health system initiatives in the budget for this year is 1.8. For the incentive grants, it's 1 million.
Okay, so, right. Okay.
And that incentive grant budget is split between schools and communities.
Just curious, what peer support systems are in place? I mean, most addiction recovery, when there's a peer support system in place, seems to be more effective. Have we found some very good peer support programs to complement what we're doing here?
So the Department of Mental Health's program actually uses their peer recovery support specialists to function as wellness champions and wellness coaches. And so they add on those wellness services and tobacco counseling to the existing peer recovery support model.
Does it appear to be very effective?
I mean, they've trained thousands of them. And they have waiting lists for more people that want to do it. And so they're definitely billing for the services. They're being utilized, and they're reaching, the clients that they're aiming for.
So I'm confused now. This whole presentation was about health system incentive grants, but that shows up in the budget in two different places. Is that correct?
No.
So this is,
go ahead.
Oh, this is the health systems initiative grants. And so it's separate from the incentive grants.
Marshall, on your budget if you're looking at the FY program budget, that's line 61.
Right. I got it.
And then the other one I think that you're looking at then is line 86. And those initials are community and schools.
Okay. Thank you.
That's scary when I can think like you.
You're learning.
Yes, you're rubbing off on me.
I have one question, and this is just a point I'm trying to make sure I understand. In your presentation where it talks about number of fewer smokers, does that actually include all types of tobacco use, like people that use dip skull and that kind of thing? Or is that just mean smoking cigarettes?
It is cigarette smokers. The PRISM model only takes cigarette smoking into account because there's the largest evidence base behind that.
Thank you.
And so general tobacco use, it doesn't project out.
Okay.
Heather, back on the hospital association under the Work Healthy Hospital, when you got to the PRISM model on that, that's combined, both the patient and the worker. Is that correct?
Yeah.
Is there any way to know if one or the other, did it break it down as far as the healthy work hospital workers coming out?
We didn't do that this time, but I think that would be possible for the future. It's a safe assumption that the majority of the tobacco users are being impacted by the hospital's Helping Patients Quit initiative. And then anything to do with obesity is going to be limited to Work Healthy because that's the only program that addresses obesity within OHCA's program.
Okay.
Any other questions? All right, thank you, Heather. And that ends the program committee report. We are now ready to progress to public information and outreach committee report. Casey.
Okay. In your packets, and let's see if I can find the page number. It's somewhere down there. We start on page 69, I think. Yeah, 69. We have two resolutions to consider. One is an update on our tobacco policy, and the other is a new resolution on obesity. And I'm going to turn it over to Thomas to go through those. I'm sure we've read all the whereases and whatnot, but Thomas, if you want to take it over and kind of go through that and how they'll be utilized.
Okay, well, since we may have people joining us by phone, I'm going to go ahead and read through both of these resolutions. So I will do the update on the tobacco resolution first, and I will read it, and then board members can discuss and vote to adopt it. The resolution states, whereas the Oklahoma Tobacco Settlement Endowment Trust, or TSET, has a constitutional mandate to support strategies and programs designed to maintain or improve the health of Oklahomans. And whereas TSET also has a constitutional mandate to support cost-effective tobacco prevention and cessation programs. And whereas in 2006, a U.S. federal court found Altria, Philip Morris USA, R.J. Reynolds, and other tobacco companies in violation of the Racketeer Influenced and Corrupt Organizations Act, or RICO, citing 145 distinct acts of racketeering in a 1,682-page ruling, United States versus Philip Morris, and finding the company's fraudulent conduct has permeated all aspects of their operations, that they would likely continue committing fraud indefinitely into the future, and that their conspiracy sought not only to misinform the public, but also lawmakers. And whereas Oklahoma's laws still do not include full protections from tobacco use and secondhand smoke for adults and children, and current Oklahoma law includes provisions supported by the tobacco industry that continue to entice youth to begin using tobacco, keep tobacco users addicted, expose workers to toxic secondhand smoke, prevent cities from protecting citizens from secondhand smoke exposure in their communities, and create an uneven playing field for some businesses. And whereas smoking remains the leading cause of preventable disease, disability, and death in the U.S. and in Oklahoma, despite progress in reducing the smoking rate below 20%. Every year, 7,500 Oklahomans die from smoking-related illnesses, and tobacco costs the state over $1.6 billion in healthcare costs annually. And whereas smokers and those unprotected from secondhand smoke are at risk of serious health problems from cigarette smoke, including cancer, stroke, heart disease, and lung disease. And whereas, as an additional $1 tax per cigarette pack implemented in 2018 to encourage people to quit smoking and to help fund education, resulted in a reduction in purchases and an 85% increase in calls to the Oklahoma Tobacco Helpline in the first months after the tax increase. And whereas, although cigarette use has declined in Oklahoma and nationwide, use of new tobacco delivery devices, such as e-cigarettes, flavored nicotine, and vapor products is on the rise, and these products are not included in the state's statutes as tobacco products and are not taxed at a comparable rate. And whereas 9% of Oklahoma youth have reported smoking cigarettes, and 31% of them have reported using e-cigarettes and other tobacco products. And whereas death and illness from additives and faulty batteries in e-cigarettes have also increased. And whereas the TSET Board of Directors supported raising Oklahoma's tobacco purchasing age from 18 to 21, and that measure was signed by Governor Stitt on May 20th, 2020, after legislation passed in December 2019 that amended the Federal Food, Drug, and Cosmetic Act and raised the federal minimum wage of the sale of tobacco products from 18 to 21 years. Be it therefore resolved, the TSET Board of Directors supports efforts to enact comprehensive clean indoor air laws, prohibit smoking in cars with minors, ban menthol and other flavored tobacco, vaping, or smokeless tobacco products, enact meaningful price increases on tobacco products, including vaping products, within the next decade, push for nicotine cartridges to meet child-resistant packaging standards, strengthen laws that prevent young people from having access to cigarettes and other tobacco products, and support adequate enforcement of those provisions, focus enforcement on retailers who sell tobacco and nicotine products to youth instead of on youth that use, purchase, or possess these products. Modernize employment laws to allow employers to support tobacco-free environments. Encourage e-cigarette and alternative nicotine or vapor products to be taxed in retailers to obtain a tobacco retailer license. Repeal preemption measures that prevent local governments from enacting policies to protect the health and well-being of their citizens. Reduce retailer density by limiting the number of licenses in an area. Require distance between vaping retailers, limiting retailers by population size and ensuring they are not located near schools, eliminate cigarette and smokeless tobacco product advertising, marketing, and sponsorships when possible to assist in reducing its use. Furthermore, be it therefore resolved, the TSET Board of Directors respectfully recommends the adoption of the aforementioned policies which, when enacted, in combination with enhanced investments in tobacco use prevention and cessation efforts, are expected to cut Oklahoma's adult smoking in half by 2028 and to prevent young people from starting tobacco. The TSET Board of Directors hereby calls upon other interested groups and governing bodies to adopt similar resolutions.
Well read.
Thank you.
Discussion from the board.
You're muted, Casey.
Okay, there I am. Sorry, wrong buttons. Okay. Okay, we have the resolution before us. We talked about it in committee and asked the staff to come back with stuff for us here. So really we need to open this up for discussion and look at that as it is. So thoughts on the resolution?
So Casey, is your committee recommending this?
We're going to go for a motion here because we actually didn't get to review the whole thing in committee.
But generally
we do want
speaking,
to, yes, we do want to have a resolution. We were in favor of that, and asked staff to go back and double check with council as to what all we could put in it and, you know, where we can move forward, you know, preparing for the fall season that's upon us. And so really just to kind of look at those things. It's a renewing and kind of a few updates on the old policy and resolutions that we've done before.
so you're happy with it?
A couple of tweaks, a couple of questions.
Okay.
One, and it's just a picky thing, Thomas, on the first page, there's a 1, 2, and a 3 footnote, but I don't see the number 3 on your page. Is that the 1 billion in healthcare cost? It's in your 1, 2, 3, 5th whereas.
So the 3 is 3 whereases up from the bottom. It is smokers and those.
Oh, there it is. Okay, I'm sorry. Yeah, okay. Okay, that was my bad. And the thought just crossed my mind when I was thinking about it. Is there some whereas that we could put in there? How important the concept of the endowment is and how voters in 2000 voted to establish an endowment for perpetuity, something along those lines? Or is that not needed?
I don't think it could hurt. I mean, let's word it politically correctly, whatever that means.
Right.
So I would say there are ethics laws that prevent state boards from taking positions on pending state questions. I don't know if our attorney is on, or if Susanna, you have some expertise to lend, but we can talk about the wisdom of the endowment and preserving dollars. However, if we were to take a position as a board, Michelle, attorney as well, that would be outside of what we are allowed to do as a state-funded entity. And in this capacity, you are acting as state officers.
Well, and I think more just in a statement of support of the endowment, the concept of an endowment, and something in regards to, you know, long-term, and I don't know, maybe we can't, but that was just, I mean, you guys know my feelings on resolutions. I think it's going to we're going to put it out there and no one's going to pick it up.
Well, maybe somebody will. I mean, we've got a few legislators there that would be happy to have a little bit more ammunition to maybe disagree.
Right. Yes. Yes.
So again, I don't think we have to take a political position, but just reminding people of how we got here, why we're here, and how it's funded is, I don't think that's inappropriate.
Well, I think the more that we can say it, the better.
So what if in the very first whereas, could we put in, whereas the Oklahoma Tobacco Settlement Endowment Trust was created by voters in 2000 and has a constitutional mandate, etc.
I love it.
Yes.
Okay.
Okay.
I mean, you're just stating facts. You're not stating a position. You're stating facts.
Okay, so that, as amended, that first whereas would read, whereas the Oklahoma Tobacco Settlement Endowment Trust, TSET, was created by voters in 2000 and has a constitutional mandate to support strategies and programs designed to maintain or improve the health of Oklahomans.
Yes.
Is that correct? Okay.
Mhm.
I mean, that's appropriate. It's accurate, and it's not political.
Yeah. Ken, you're our other committee chair. Can we present that from the committee?
I think it's just straight facts.
Yeah.
Well, I like the language.
Yes, now it's from committee, Bruce. We like it now.
Okay.
Need a motion to approve as amended.
Yeah, we need a motion to approve as amended.
I would make that motion.
I will second.
It's been moved and seconded. Roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblane,
Yes.
Susanna Guttoni,
Yes.
Ken Rowe,
Yes.
Marshall Snipes.
Yes.
Awesome. Okay. Our next one is in regards to the reduction of obesity, and this is a new resolution for us. So Thomas, take it away.
Okay. Whereas the Oklahoma Tobacco Settlement Endowment Trust, TSET, has a constitutional mandate to support strategies and programs designed to maintain or improve the health of Oklahomans. And whereas Oklahoma places 46th in health rankings among the United States, in part because of its low ranking on the health indicator regarding obesity. And whereas obesity is an increasing health epidemic, with 1 in 3 Americans and 35% of Oklahomans were obese as of 2019, including 7 out of 10 adults in Oklahoma that are either overweight or obese. Whereas being obese or overweight is linked to poor health outcomes and chronic diseases, including gallbladder and liver disease, heart disease, high blood pressure, osteoarthritis, sleep apnea, type 2 diabetes, stroke, and 13 types of cancer. And whereas healthcare costs directly attributed to obesity in Oklahoma annually exceed $1.7 billion. And whereas to reduce these costs and improve the health of all Oklahomans, a whole community and prevention-oriented approach to solving the obesity epidemic should be taken. And whereas the approach should involve ensuring all Oklahomans have access to nutritious food, places to be physically active, safer water to drink, adequate sleep, limited screen time. And whereas within a whole community approach, community groups, lawmakers, schools, child care workers, employers, healthcare providers, public health professionals, and residents work together to support and promote healthy lifestyles and create settings that prevent and reduce obesity. Together, they can reduce barriers to healthy activities, improve access to health promoting choices, advance fiscal and social resources, and build the collective capacity in communities to achieve their full health potential. Be it therefore resolved, the TSET Board of Directors respectfully encourages the public and state and local leaders to embrace policies that encourage active lifestyles and health promoting dietary choices and programs that teach wellness and healthy lifestyles. And furthermore, be it therefore resolved, the TSET Board of Directors supports efforts to ensure that all Oklahomans have access to a healthy diet, pass governmental policies that prevent and reduce obesity, encourage workplaces to help employees to be healthier, improve access to healthy, affordable, and culturally appropriate foods in neighborhoods and rural areas with limited options, achieve adequate food security for low-income populations, encourage communities to plant community gardens, increase safe access to recreational facilities, and provide nutritional information on menu items and education about how to change unhealthy behaviors, assist schools in providing more physical activity, healthier food, health education, and planting school gardens, improve access to physical activities for all Oklahomans, encourage childcare providers and parents to engage children in active play and to play with other children, help communities and neighborhoods to have low-cost physical health opportunities to create a more active environment, particularly by improving pedestrian and bicycle infrastructure, educate about the importance of drinking water and how sugar-sweetened beverages can contribute to obesity. Also, encourage schools and communities to adopt policies to improve and expand safe drinking water access, limit screen time, particularly among children, encourage enough sleep, support healthcare providers to educate patients on the importance of a healthy diet and lifestyle. Furthermore, be it therefore resolved, the TSET Board of Directors calls on the Oklahoma Legislature to support policies of these aims, such as repealing the sales tax on healthy foods, funding health education and physical activity courses for all Oklahoma public school students, payment for clinical obesity-related prevention and treatment visits, funding and supporting complete streets, safe routes to schools, and other active transportation measures, supporting farmers markets, investment in new grocery stores in rural or low-income areas, farm-to-school programs, community gardens, and other initiatives that promote local agriculture and access to healthy food, working to reduce food insecurity and increase access to healthy food choices in Oklahoma communities. Further, be it therefore resolved, the TSET Board of Directors respectfully recommends the adoption of the aforementioned policies and strategies to prevent and reduce obesity and to improve the health and well-being of Oklahomans. The TSET Board of Directors hereby calls upon other interested groups and governing bodies to adopt similar resolutions.
Okay. I would advocate again, we add that other whereas in there. TSET was established by a vote of the people in 2000.
We can do that.
I also have a change I'd like us to make in the second bullet point on the first furthermore on page 74. I think we should say pass governmental policies. That's the same thing as laws, right?
Yes.
That encourage prevention and reduction. Everywhere else in this document and the previous document, we were encouraging those kind of behaviors until we got really specific, like repealing sales tax on healthy foods. But to me, that's a little strong. Pass government policies that prevent obesity. I don't know how you'd ever do that. If somebody wants to be obese, they're going to be obese. I don't think we want to get into the business of requiring a person not to be obese. You could read that into that.
So that bullet point, as you amend it, that would read, pass governmental policies that encourage prevention and reduction of obesity?
Yes.
Okay.
Yeah.
All right, we've got it.
Okay, any other comment? This requires a motion and second for the amendment.
So moved.
All right. Second.
We have a motion and a second. Any further discussion? Roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblain,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
Marshall Snipes.
Yes.
Okay, moving on to our next item under public information, and it's an overview of our TSET Healthy Youth Initiative that we had voted to take on and begin that. And of course, we're kind of pushing as hard as we can on this. And we have with us today the CEO of Rescue, Jeff Gordon. So Jeff, we're gonna let you take over and go through this with us.
Thanks so much, Casey. And I wish I was Jeff Gordon, the race car driver, but Jeff Gordon. So real quickly, wanted to introduce you to the work. First of all, thank you very much for approving us as the contractor to do this work. Our contract initiated on July 1st, so less than 2 months ago. And this is the phase 1 of this work that TSET is doing. We just real quick, a little bit of glossary. We use the term message package throughout this presentation to describe what would be a commercial and all the things that come with that commercial. So whether that might be social media, digital media, everything that kind of wraps around one message that a campaign is going to deliver. And what we have proposed and have already begun doing is that our first 4 message packages as a part of this contract will be focused on preventing and reducing teen vaping. And they have already launched as of October 3rd, which you all were sent those first 2 ads, and then the next 2 you will be sent as they are selected. And these are pre-existing, pre-tested advertisements that we're using in Oklahoma. The social and digital media will run the duration of the entire contract pretty much as of August 3rd, excuse me. And the TV, cable, and radio will run from August 24th through 31st, and again from September 21st through October 1st. So an always-on social digital media approach and a flighting of TV, cable, radio, which is actually administered by VI, which is TSET's agency of record, as you know. A very quick introduction about us. So we are a rescue agency. We've been promoting healthy behaviors to youth since 2001. That's all we do is promote healthy behaviors. We work exclusively in this positive social change space within health. And we work with over 20 states like Virginia, South Carolina, North Carolina, Kentucky, Mississippi, Louisiana, Kansas, Indiana, and another dozen that I can name there. And our expertise is that we've pioneered strategies and campaigns to reach teens more authentically and effectively, including something that I am not aware of anyone else doing, which is a rural first strategy that really understands that rural teens are different from urban teens, and that they need messages designed specifically to them if we're ever to hope to decrease the health disparities between rural, suburban, and urban areas. We're also proud to be national leaders in tobacco, including the development of national campaigns like the FDA's campaign Fresh Empire, which is its multicultural teen tobacco prevention campaign. And we're happy to say that we've been working with you in different capacities since 2010. So we're very proud to be a long-term TSET partner. So on the next slide here, the other thing I wanted to point out is that everything that we're going to be doing is science-based and evidence-based. We have an in-house research department of about 20 researchers, including PhDs and MPHs, whose focus is to conduct the research that informs our campaigns, but also analyze the campaigns and the outcomes to contribute to the overall public health literature and really make campaigns more effective over time. This team has over 20 published tobacco prevention studies in journals such as Tobacco Control and Health Education and Behavior, including one that we published in collaboration with TSET called Wreaking Havoc on Smoking, Social Branding to Reach Young Adult Partiers in Oklahoma, and others that are informing the work we're doing in Oklahoma, such as one from 2018 called Freedom from Chew, using social branding to reduce chewing tobacco use among country peer crowd teens, and then The Vaping Teenager, which was just published, that is understanding the psychographics and interests of adolescent vape users to inform health communications campaigns. So really hyper focus on understanding who teens are, what makes teens different, and how we can kind of leverage those differences to really make sure the messages reach the right teenagers. Next slide here. So the first campaign that already launched is called Behind the Haze. And Behind the Haze, hopefully you've watched the commercial. If not, be sure to check it out. It focuses specifically on teen vaping education with straightforward facts, without exaggeration, without fear tactics, really encouraging teens to think on their own, to rethink their own decisions. Give them the facts and let them make those decisions for themselves. All the ads that are being used in Oklahoma have been tested across multiple states, many states with similar geographics and demographics as Oklahoma. And it challenges teens' perception that vaping is an acceptable risk. So what we've heard from kind of the average, let's call it like the popular teenager, is that they see vaping as something like staying out late past curfew on a Friday night. You know, it's a way to rebel that's probably not going to cause that much trouble in their life. We want to change that perception, and we want them to know that vaping is a highly addictive substance that can lead to health consequences. And really focus in on those health consequences, many of which are just being discovered right now. So this is a lot of new information that we're delivering to teens. And we really have a two-step challenge here. Our first step is that we have to make teens want to stop vaping before we can help them stop vaping, right? So we want to help them as well, but they have to want to stop vaping first. And that's the goal of Behind the Haze, is get teens on their own to decide they don't want to vape anymore. Which then leads to the help that we will provide, that TSET will provide through My Life, My Quit, which we'll talk a little bit more about in a second. The second campaign that's going on concurrently is called Down and Dirty. And Down and Dirty is designed specifically for rural teen tobacco prevention. This was developed using research that shows how rural teens prefer to receive information. So we've done probably over 100 focus groups now with rural teens across different states, and they process information differently. They prefer different methods of delivery of that information. The easiest way to understand it is the notion of the fast-talking city slicker like me, which is actually very not trustworthy to a rural teenager. They see that as someone outside of their community, and they want to hear from someone like them, who doesn't talk quite as fast, who doesn't try and throw a lot of things at them, but instead just focuses on making one clear point in a very straightforward, kind of often talking to the camera kind of way. So Down and Dirty ads look very different from Behind the Haze ads, but they are trying to do the same thing, which is reduce tobacco use and get teens on their own to decide that they don't want to use tobacco anymore. While Behind the Haze is specifically focused on vaping, Down and Dirty has the ability to expand on multiple tobacco issues. So it has pre-existing content for vaping, as well as chew tobacco use, as well as cigarettes. And so we're starting with vaping messaging, but as we look at the numbers along with TSET, we can choose to throw in some other messages to really do a comprehensive tobacco-free message, and really hope to close the disparity between urban and rural teen tobacco use by having these mutual, these kind of concurrent strategies going on in both the urban areas of Oklahoma as well as the rural areas of Oklahoma. And Down and Dirty 2 will push to My Life, My Quit that we'll talk about. Next slide. One of the best things about Behind the Haze and Down and Dirty is that TSET has chosen to license pre-existing tobacco prevention campaigns rather than develop them from scratch. And this is something that is that saves a lot of money for TSET and allows those funds to be used to deliver the interventions instead of the creation and development of the interventions. So we estimate that it saves around 80% of the development costs to license these ads instead, and reduces the time to launch by over 70%. If we didn't have these ads, we would not have been able to receive the contract on July 1st and launch the campaign by August 3rd. Right? That was only possible because we already had pre-tested ads from multiple states that have already shown to be effective. And why reinvent the wheel when it's already there, right? You know, I'm a business guy. As a businessman, I would not want to just spend a whole bunch of money doing something when there's a perfectly good solution already around that would work in my area. And that's where this idea of licensing came from. Oklahoma also benefits from the research already conducted with these teens, but Oklahoma remains fully in control. So there's a library of ads and message packages that Oklahoma will choose which ones it does and does not want to air based on the research available. And we will be doing ongoing research in Oklahoma for future decisions. So it's not that we won't have research from Oklahoma. We will continue to test these ads, and then Oklahoma will be able to choose which ones are best suited for its local teens. And finally, Oklahoma benefits from the continuous improvement of message packages that have already been implemented in other states. So for example, the ad that we're airing for Down and Dirty, it's been aired in 3 or 4 other states. And based on the information we've received from social media from those states, we've tweaked the message over time, improved the social and digital media. So you're getting a more tried and true product than you would get from something that's brand new and not yet field tested. Next slide. And as I've mentioned a few times, My Life, My Quit. So TSET has separately contracted with National Jewish Health to bring their teen-focused cessation program, My Life, My Quit, to Oklahoma. This program provides cessation services specifically designed for teens. And coincidentally, we had begun working with National Jewish Health in May to develop a message package to promote My Life, My Quit in a really cool way to teens that complements Behind the Haze. So Oklahoma is also going to be able to use that message package that was developed for National Jewish Health that's actually being used by, I think, 10 different states beginning in October to promote the cessation services in the state. And since we developed it, it will plug right into the strategy that's going on, right into the media that VI is doing, and really complement this well. So an engine of 3 different partners here between National Jewish Health, VI, and Rescue that are working very closely to deliver this in Oklahoma. Next slide. So that's the tobacco work. Now, for the teen obesity prevention work, unfortunately, there's not a lot of states doing teen obesity prevention. So there wasn't a lot that we could pre-existing that we could use, or else we would have used it. And so in this case, we do need to develop strategies from scratch. Now, while that takes a little bit longer, the plus side is that TSET gets to be an innovator and a leader in the field because there really isn't a lot of effective programs out there for teen obesity prevention. So right now, what we're doing is we're developing these new strategies, and we're going to go into research next month with Oklahoma teens to vet these different strategies. And one thing that we are benefiting from is some general nutrition research that we've been doing over the years in a few states that tells us that the biggest kind of challenge with obesity prevention work is that it doesn't tell you exactly how to change. Right. So you've heard things from like the national stuff, like My Plate and things like that, that just says, eat more vegetables, eat healthier, etc. And what we hear from people on the ground that are actually making these decisions is that they don't know what that means in their life. So they don't know which behavior to switch, which food to change, etc. One of my favorites is someone in a focus group once told us they started eating healthy, and we asked them what that meant. And they said that they added an iceberg lettuce salad to their meat and potatoes covered in ranch. And we said, so did you take anything out? So no, I just wanted to get some vegetables in. So now I'm eating my iceberg lettuce with more ranch calories than we could probably count. So this is why just kind of a lot of people misinterpret the message to eat healthier. We want to give teens really clear information on not just what to switch, but that is accessible. So if they're going to a convenience store to buy their bag of chips, we want to give them an alternative that is also available in that same convenience store. If they're going to fast food to buy a hamburger, we want to talk about a grilled chicken burger, that grilled chicken sandwich that's also available at that same fast food restaurant, right? So we want to make these changes easy, very simple. And the biggest thing we're going to do is we're going to communicate to them why these changes are so impactful by talking to them about how food makes them feel. So how it is that eating unhealthy makes you feel in school, feeling lethargic, feeling like you can't think clearly, how it makes you feel at football practice, feeling like, you can't run as fast, you can't go as long because you haven't been eating, or what happens in a sugar crash happens in the middle of a game. All these things that unhealthy foods cause for you to feel, so that they can start to connect these negative feelings in their life with the foods that they're eating that we would prefer they not eat. And so all of this is coming. We're in the middle of that thought process of development, and we'll be testing that shortly. And on the next slide here, both campaigns, the tobacco prevention and the obesity prevention efforts, will be evaluated by a statewide survey that the baseline has already begun of about 400 to 500 Oklahoma youth that will be filling out this online survey. And then we will be following up with about half of them every 6 months. So the first half, 6 months, the next half, the other 6 months, over time, over the duration of this contract, to track, first of all, their exposure to these campaigns, their attitudes and perceptions of these campaigns, how their own attitudes are changing around vaping, food, et cetera, and see how the campaigns are being impactful. So this will hopefully be a precursor to you seeing changes on the youth, on the more formal representative youth surveys. We want to make sure we're seeing more real-time data that can allow us to adjust and take action. And this will be both from rural and urban areas. We have a lot of experience making sure that we get a large rural sample so that we can do rural analyses as well as urban analyses. And last slide here. So the future plans for this initiative, right? This is our first year plan. They will be built based on this data that we're getting from Oklahoma teens, but it will also be informed by other statewide surveys, such as the Youth Tobacco Survey, the YRBS, as well as the Adult Survey. And what we're learning from Shape Your Future and Tobacco Stops With Me, we'll also be taking those lessons to help inform us on these campaigns. We'll also, on the rescue side, we'll be monitoring national trends and studies that to make sure that the Oklahoma work has the best opportunity to cause impact. This is what we do all day, right? We're working in vaping all day. We're working in obesity prevention all day. So we're already monitoring that stuff, and we will share any relevant research findings with our work in Oklahoma. And our hope is, just like we were able to previously publish, we hope to also publish research from both of these campaigns from our Oklahoma work in collaboration with TSET. And with that, I'm happy to take any questions.
Well, I know my granddaughter doesn't trust you, but you really make a good show.
Thank you. Got to put the right people in the right audiences, right? So
actually, speaking of granddaughter, I was with my 17-year-old granddaughter listening to her radio station, and in a period of about a half hour, there were 2 non-vaping commercials. They were not sponsored by TSET. Who else is out there doing that? Because they're really pretty good commercials, I think. She may not think so.
Yeah, that might have been either the Real Cost, which is the FDA's vaping prevention campaign, or it might be Truth. Yeah. And those have been around. So there is some great work coming out of the Real Cost in particular. One of the, but vaping rates are still going up. So it's kind of this, presumably they are holding back vaping from going up faster, but it's clear based on the rates. We just got the 2019 rates, and they are just astronomical. That we need as many cooks in this kitchen to turn the tide.
Absolutely, it's way worse than smoking at that age.
Yeah.
What are the rates, Jeff? What's the latest?
I'm thinking of the national rate that I think it hit 30% past 30-day vape use. And over 50% of teens have tried a vape. In order to find cigarette rates that are this high, you would have to go to the mid-90s. Yeah. So this is more than 20 years of tobacco control that's potentially being undone by vaping. I don't have the latest Oklahoma rates if someone has the 2019 rates.
Well, they're probably not any better, and most likely worse.
Yeah.
But you can combine vaping with smoking, and the total is, it may be 40%.
And I would guess from the reports I get from my daughters that are high schoolers in a 4A school that it's much higher than 30%, much, much, much higher. Mm-hmm. In fact, they would tell me that the majority of kids vape or vape occasionally because it's so easy. They put it in their jacket and they vape during all of class. And now that we've got masks on, it's even easier.
Yeah. Now, the one silver lining I'll give you with that notion is that teens who smoke cigarettes also say everyone used to smoke cigarettes 10 years ago. So hopefully, teens always do exaggerate a little bit. If they do it, everyone's doing it. But or if their friends do it, everyone's doing it. But certainly I wouldn't be surprised if the rates in Oklahoma are higher.
Do we have, I mean, what is our data? Does anybody know that? Julie or Sana?
We're supposed to be getting the data this week or next week.
Okay.
They released the national information and states are just now getting the state breakdowns.
Okay.
This is super fresh. I think it came out last week. Yeah.
Right. Okay. Well, I think that's exciting. Any questions? Any more questions for Jeff? Anybody?
Keep the faith.
No, but it's awesome. I'm so excited. I'm very energized by this.
Awesome. Yeah. Well, thank you for giving us this opportunity. And I'll be back tomorrow to talk to some of you. So if you think of anything, feel free to ask me then.
Thanks, Jeff. Great to see you.
Thank you.
Okay.
Bye-bye.
Okay. Item C in our public information, lots of pages in your packet on all of this information. I'm just going to hit some of the highlights quickly. And you can go back and look through things. Our brands, Tobacco Stops With Me, Shape Your Future, Tobacco Helpline, and now the new My Life, My Quit, and the phase 1 of TSET Healthy Youth Initiative. God, I can't talk. Things are all online. We're moving forward with our communication plans, and there's just a lot of fun stuff. New media is being launched this week and over Labor Day weekend. Those will be up on our YouTube channels once they get launched. Shape Your Future will be expanding messaging to include getting adequate sleep, reducing screen time, getting physical activity, eating healthy, reducing sugar sweetened beverages. So we're expanding some of that conversation. The last quarter, we continued to leverage our messaging through partnerships with the Southern Plains Tribal Health Board, Scissortail, Farmers Market. I keep saying I'm coming up on Saturday. How's that going out at Scissortail? I really want to come to the Farmers Market, but an hour and a half might seem a little long to drive.
It's been pretty fantastic.
It looks fun. Different things that we're working on. The evaluation of our health communication brands continues, and we'll have presentations scheduled in upcoming meetings for a more in-depth look at some of those. We have received some awards, which is always fun to report. We got an award from the Society of Professional Journalism, the Oklahoma chapter. We got a first place for our Tobacco Stops With Me blog. We got a second place for Shape Your Future newsletter and the Tobacco Stops With Me Ronnie Trentham story. Trentham, I can't say it. We've published papers in June in the peer-reviewed BMC Nutritional Journal, factors associated with sugar-sweetened beverage consumption in adults with children in the home after a statewide health communication campaign that was done. We also have been notified of 2 presentations that have been accepted to the CDC National Virtual Conference of Health Communication, which is October 6th. We will be presenting what search marketing can teach us about psychology and how to creatively reach tobacco users. Our FAO, the Public Health Academy of Oklahoma, has finished its transformation and transitioning to a new learning management center. That went without a hitch, which is great. And we actually did training with the new Healthy Living program cohort. So that's working well. Outreach updates and activities. We've distributed press releases. Julie continues to author a monthly health forum in the Journal Record. Our PIO team is responding to lawmakers' requests for open records requests and different things, especially after HLP2 went out. There was lots of conversation, and hopefully we answered those. Well, I know we have, but it just seems to continue to come up occasionally. We're executing our fall outreach plan to identify those key partners that we need to be talking with. And of course, we'll spend some time tomorrow in our retreat looking at the upcoming activities and what all we need to be doing. They've developed a video outreach plan to educate Oklahomans on the agency's programs, short videos, and those will be published on our YouTube channel. Newsletter continues to get an open rate of about 17%. Surveys have gone out and they're looking at ways to look at that to make adjustments and scheduling things. Let's see what else. Sponsorship. We're down to that. Item E. We've approved $3,250 for sponsorship grants for this fiscal year. And upcoming events for the current future or near future, I guess. Healthy Living Program grantee orientation is on September 2nd. The Oklahoma Senior Games, which I was a member of at one time, is September 5th through November 7th. And the Oklahoma Public Health Association annual conference will be September 22nd and 23rd. I'm sure I left something out, but it's in your packet if you need to peruse it or have questions. We'll try to answer them.
All right, thank you, Casey. I'd now like to recognize Marshall Snipes for the Agency Operations Committee report.
Thank you, Mr. Chairman. If you'll all go to page 103 in your packet, if we can get that slide up. It's the first thing we're going to talk about. The investment committee, or excuse me, the operations committee has, I'm sorry. Can we get the slide up? That's the calculation of certified earnings.
We don't have it as a slide, but we can work on that while you talk about it.
Okay, well, it's in your packet. You've got a calculation of the certified earnings. There's a couple of things to point out on this schedule. This comes from the treasurer's office through the Board of Investors. The Board of Investors has an investment advisor that advises that board on how to make investments. And this is the results of that. And if you go down to the line that says available for certification, you see the $40 million number, $40,985,739. That's the amount that has been certified, which would be for FY22. And I think all of us are aware, especially if you look at the 3-year rolling average report that we'll get to in a minute, that is a significant decrease from the prior years as well. And if you'll all recall, in our budget process for the current year last spring, we anticipated this and we reacted accordingly with a modest decrease in our overall budget of 5% that was spread out across the board for the most part. So I'm sure we'll talk a lot more about that tomorrow in our offsite meeting tomorrow. The next slide, the operating results from last year and the program results from last year in your packet. I'm not going to go over any of that. You've had a chance to look at that. We are below budget as we normally are. Eventually we'll be, when all the bills are paid, as Julie mentioned earlier, we'll be up in that 95% range. So we will have spent less than we budgeted. The next slide is the balance sheet. If you'll go to that slide, that would be slide 106. This is the first time we've had this report. I'm pleased to say that the operations committee had recommended this in the past, and this is our first chance to get a balance sheet report as what that looks like. We'll be talking more about this tomorrow, and then in our next quarterly board meeting when we have our audited financials available to discuss all this. I'll just point out a couple of quick things. If you go down to line 13, that's really our investments minus our liabilities. And at that point, the liabilities primarily were the remaining budget items from FY20. And if you'll look on down on line 14 and line 16, if you add those two numbers together, that's about $250 million. And that is the amount that is sitting in our account over and above what the tobacco companies have given us. And that is made up of the certified earnings for next fiscal year and the unspent certified earnings for the current year. If you look down into the uncertified gains and losses, the 167 million, that is where our board of directors reserve resides. And so that's clearly in excess of our reserve. So we've got some cushion there, and we'll get, like I said, we'll get into more of that tomorrow. Okay, next slide, which is our operating budget for the current year. We're just barely started into that. So the next 2 slides are just for information. There's not much to discuss there. So if you'll go on down to the 3-year rolling average slide, and I think everybody except our new board members aware of this, but several years ago, the board made the decision to not spend all the certified earnings every year, but rather to spend based on a 3-year rolling average of prior certified earnings. And that has turned out to be a very wise decision. It allowed us to maintain some level of comfort in our FY21 budget to keep things relatively the same without having to dip into reserves. Now, as we get into FY22 and FY23, you see our reserve fund will be tapped into, assuming that the earnings are what has been projected. So I think this is pretty conservative, but it does illustrate that the 3-year rolling average works. Our reserve was built for just exactly these kind of times, and that has worked very well. As we do next spring, this will become really important when we talk about FY22 budget. But as you can see in the report, we're still projecting the budget to be relatively flat. That would be line 7 over the next couple of years. And in order to do that, we would have to dip into the reserve. So that's pretty obvious there. Okay, next slide.
Should be a current commitment.
That's the current commitment slide. So I'll go ahead and just tell you that is in there for your information only. We do approve everything every year, but we do tell some of our grantees so that they can make their longer term plans relative to payroll and those kinds of things that we do kind of approve those things conceptually for longer periods of time, but legally we only approve them once a year for the actual expenditure. So that gives you a good snapshot of where we are relative to those commitments. So that is the end of my report, Mr. Chairman.
Thank you, Marshall. Any board questions for Marshall? All right, thank you. We're now at the time of the agenda where we can open the floor for public comment. I'd like to note that if you're joining through your computer or Zoom, you can raise your virtual hand or state your request in the chat feature. If you're joining by phone and would like to participate in the public comment, text your name and phone number to 405-642-6860. I will recognize you when it's your turn to speak, and you will be unmuted. Comments will be limited to 2 minutes and must pertain to items listed on the agenda. Obscene or offensive disruptions or comments in the chat will get the offender removed from the Zoom meeting.
Give people a few seconds to text or raise their hands.
Okay, we'll now wait for a minute or two. Give people time to respond.
I'm so tempted to say something crude so you'll kick me off.
If it works, I'll follow suit.
We're real close, guys.
It's been a great meeting. Everyone's done a wonderful job. Thank you.
Thank you. We've got a great team.
Yeah, we don't have any public comment, it seems.
Okay, without any comments, we'll move to new business. Any matter not known about or which could not have been reasonably foreseen prior to the time of the posted agenda, we're now open to that business. In the absence of any comment, we're now down to our final item, which is adjournment.
So moved.
What, we have, hold on just a second.
Sorry, just real quick for those following at home, we will have board retreat tomorrow. It is posted, and the meeting will be at the admin conference center. That's all.
Okay. Do I have a motion?
So moved.
So seconded.
Been moved and seconded. Roll call.
Bruce Benjamin,
Yes.
Michelle Stevens,
Yes.
Jack Allen,
Yes.
Casey Kilblain,
Yes.
Susanna Gattoni,
Yes.
Ken Rowe,
Yes.
Marshall Snipes.
Yes.
I hope you enjoyed your first meeting, Susanna.
Exactly.
Thank you.
All right, welcome. And with that, the meeting is adjourned.
Okay, party on. See you kids tomorrow.
All right.
Bye.
8 o'clock tomorrow, Julie, is that
It starts at 9 a.m. tomorrow in Edmond.
I'll be there at 8.
it?
Well, my schedule said 10. You guys start without me.